Following out-of-hospital cardiac arrest, focus turns to the underlying cause. Should patients without an obvious cause undergo emergency coronary angiography? Or should this be delayed until the patient recovers? Let's take a look at the EMERGE trial in this episode of Osler Shortcuts. Despite the best efforts of modern medicine, the chances of discharge from hospital with a good quality of life after an out-of-hospital cardiac arrest remain low. Many of these events are caused by coronary artery disease, and while those with ST elevation myocardial infarction clearly benefit from immediate percutaneous angiography, the efficacy in those without ST elevation is unclear. The EMERGE trial enrolled 279 patients with out-of-hospital cardiac arrest. Patients had no obvious non-cardiac cause and had no evidence of ST elevation infarction on their ECG. Patients were randomized to either immediate coronary angiography or it was delayed up to 96 hours. Investigators studied the impact of this intervention on 180-day survival with no or minimal neurological damage, as evaluated by the Cerebral Performance Category score of 1 or 2. On average, patients were 65 years of age and had favorable resuscitation delivered. The time from arrest to return of spontaneous circulation was 26 minutes, which is consistent with other trials in this area. Notably, the initial rhythm was shockable in just 1/3 of patients. Around half of patients in the control arm never underwent angiography, most commonly because they died prior to the procedure. The mean time to angiography was 0.6 hours in the intervention group and 37 hours in the control. No significant coronary artery disease was found in 55% of the control group and 45% of the intervention group, while more patients in the intervention group underwent PCI. The reason for this discrepancy is unclear, but may be due to random chance. At 180 days, there was no significant difference between the groups, though the point estimate favored the intervention, 34.1% compared with 30.7% in the control group. There were no differences seen in any secondary outcome. EMERGE adds to the existing literature of 3 small randomized controlled trials. They achieved clear separation of the groups and included patients with non-shockable initial rhythms and cardiogenic shock, which were both excluded in other trials. As usual, though, we need to keep in mind some limitations. The EMERGE trial was cut short due to an unexpectedly slow recruitment rate, with only 279 of a targeted 970 patients enrolled. This clearly weakens the power of the study to find evidence of a meaningful benefit. The study was also unblinded, which was impossible to avoid, resulting in the potential for bias given the unblinded clinicians could potentially directly influence the outcome, though this does seem unlikely. So where does this leave us? The authors conducted a meta-analysis of the available evidence, including the Tomahawk, COACT and Pearl trials, totaling 1,446 patients. They found no evidence of benefit for early angiography. Importantly, though, the 2 biggest trials in this area, Tomahawk and COACT, both found a strong trend favoring delayed angiography. A Swedish trial, DISCO, is currently underway, and hopefully this will help settle the issue. If you found this review useful, why not head over to Osler and check out the great range of modules, podcasts, tutorials and simulations, which are all completely free. See you next time on Osler Shortcuts.